Thank you, sir. Can you see my slides?
Yes, yes.
Thank you, sir. Thanks for this kind invite. I'd like to thank Dr. Rohit, Namrata ma'am, Maipal sir, and Partha sir, the entire ARS team for this opportunity. My talk is something to do more with optics than with any surgical procedures. I know financial interest in what I'm speaking here. When I started off many years back, what I liked about the whole art of procedures is that you could mix your science and you would convert it into your art, which is your surgical skill. And that's where your wonder lies, if you merge both of them together. Because many times we are always more on a surgical procedures, we miss the whole mathematics and science behind it. So this was maybe 13 or 14 years back. I decided to build a small optics lab, which we call it as Novel, and it was called the Quest for Understanding Vision. At that point of time, the first tool which I incorporated into my technology was the OPD 3 scanner, which I'm going to speak today from NIDAC. Again, no financial interest at this point of time. It has a lot of application, but I'm just looking at from the cataract surgery point of view. For the customization of cataract surgery today, we need to be proper with the sphere, cylinder, spherical aberration, and how you take care of your near additions. I just stick to optics, which is the area of interest. All this are very important for a cataract surgeon today, irrespective of your skill or technology. It starts with your tear, how does the epithelium change, the stroma, the internal optics, and you have to look beyond into your retina also. So you have a map like this, which comes out from your OPD3 scanner, and it has your aberrations, you have refractive errors, spherical aberrations. It looks busy, pupil informations. But what is interesting is it gives you even the contrast at different pupil sizes. At one shot, you know what is happening to the optical picture of your eye, which is very important because otherwise, most of the time to get this much, it would take a long time, and it just takes around 8 to 10 seconds for the image to capture. Let me start with the tear film. A 43-year-old man coming to you for a cataract surgery, and his placido disc is like this, and all he has is a terribly bad corneal surface, and the machine says that your patient has keratoconus. Be aware of it. You treat him. This patient we treated with the lippy flow, and we redid his assessment. The whole cornea became more regular, and it says that it's normal. So what happens is your curvature maps, which you take from your IOL master or a lens star, is dependent on your tear film and dependent on how it works. And this is very important and this gives you an assessment of when you treat it, how does your tear film behave? And you can see that the whole corneal aberration completely changes from a poor tear film to a normal tear film. And all these things can make a huge impact in your planning. So how does it help a cataract surgeons? Of course, planning different lenses. This concept I'm going to go a little later into my presentation. When you put an IOLs, you look at many things. Your spherical errors, you look at your astigmatism, and you look at what is important today with all your new lenses coming out with the extended depth of focus lenses. You look at how your cornea behaves to spherical aberrations. So can you incorporate everything in this technology? Before we go there, we need to know where do you implant your lenses, because over time, I think we're going to be heavily dependent on the placing your lenses to the right place. You have a mesopic pupil, the photopic pupil, and the difference between them. See, all this are very important for your planning. Of course, the angle kappa comes immediately. So there's some slide issues, but anyway, this is the difference between the photopic and the mesopic. And OPD3 scanner gives you all this difference. The mesopic angle kappa, photopic angle kappa. This is very important because you are not only looking at one size of the pupil can change. And the alpha distance, angle alpha distance, this is very important. The angular distance between visual axis and the center of the limbus. So all this comes at one go, and you are able to check before you do a surgery at everything related to the axis of the eye, which is very, very important in today's practice. And there are different normative data based on this. And if you are not aligned properly, then you have issue of glare, halos, dysphotopsias, and many other things. And this is what happens when you're perfectly centered, and this is your multifocal, and you see the reflection, which is not perfectly centered, which ends up in a poor quality of vision. Now, for the premium lenses, what do we have? It gives you photopic, mesopic, distance, and pupil size for this range, higher order aberrations, everything what a cataract surgeon needs at one go. I mean, of course, this again can be used for a refractive surgery also. And it also picks up keratoconus suspects. There are a lot of keratoconus patients come to you who never known that they have a keratoconus, and you can think about planning an aspheric lenses. And this is I mean, all of us know what type of asphericity we need to correct if the cornea has a certain level of spherical aberration. So your customization becomes easier. Based on your corneal asphericity and spherical aberration, you can choose the type of lenses you want. If you want to, or you're trying to look at one of your extended depth focus lenses. The cornea is very mysterious, and that's where it's very important, because many times, like I said, is my patient suitable for multifocal? You can see that the corneal aberrations is really high here. And at one go, you know that he's not suitable for multifocal because internal aberrations are because of cataract. And in this patient, the corneal aberration is normal. It's only the internal. So even though cornea looks a little irregular, you are suitable for a multifocal lenses. And this here, everything is both are normal. So you can choose based on what you want. So virtually it gives you one set of printout, which tells you what to do. And this is a patient who had a LASIK 10 years ago, and he wants a perfect vision now. Very poor corneal irregularity. You can see that aberrations are very high. So what do we do in these patients? Again, this is a very useful tool, because in these patients, do anything on the lenses, you're going to have a lot of trouble. So what we do in these patients is we regularize the cornea with laser and then do the cataract surgery. So this is a simple example. The cornea is, you can see the aberrations are very high. We did the laser on them, just correct the irregularity. The corneal aberrations are reduced by half. So the cornea, you have enlarged the zone, and now you can see that the perfect cataract surgery and ends up with a very, very perfect vision. And this is what happens when you do this kind of procedure. So it helps us to understand all this. So customized cataract surgery, this is just a quick same slide. So I'll just skip this once. Aging lenses, this I described 10 years back. That was a time the word dysfunctional lens syndrome was not there. The lens aberration increases over time. And we are all used to this LOX classification, but things have changed today. This is a patient of mine who had LASIK surgery done many years back, comes back with blurring of vision. And what I see is the cornea is perfect. It's internally, he has got a lot of aberrations. And at that point of time, I called it as a ZERNIKE cataract. Today, it's called as dysfunctional lens syndrome. And we waited. I can see that actually over time, she developed a cataract. And we planned a cataract surgery for her, and perfectly all right. So basically, it helps to link to your biometry. It helps to get a very perfect biometry in terms of optics, perfect outcomes. It can predict, and most important, what I can say is it helps to customize your lenses. Thank you.
Thanks,